based on movies is important to people from Texas, like Dr. Ghosh. We're going to wait for a couple more minutes, see if anyone shows up, and then my name is Balin, and I'll get started with some welcome remarks and an introduction at about 12:03. Thank you. Hi, good afternoon, everybody. If you can't hear me, feel free to chime up in the, what is it called? The questions, the Q&A. But we haven't had any technical difficulties yet, so I'm going to assume that we're good to go. I want to welcome everybody to our second of 4 summertime COVID-themed speakers. My name is Balin Forcier, and I work as an analyst at VCU's Office of the Vice President for Research and Innovation. And earlier this summer, I became co-chair of the VCU School of Business Masters in Decision Analytics alumni group. And I was really excited to put together this series of 4 talks about the coronavirus, health, and business with the help of the Richmond Tidewater Chapter of INFORMS, which is the Institute for Operations Research in the Management Sciences. Quickly, I'd like to thank the Decision Analytics team at the School of Business, which is Brittany Grasick, Gabby Oliveira, Rachel Kaiser, Dr. Paul Brooks, and Dr. Steve Custer. Today, our guest is Dr. Preetam Ghosh. He is a professor of computer science at VCU Engineering and affiliate professor at VCU Health's Radiation Oncology departments. He's the secretary and treasurer of the Association for Computing Machineries, that's ACM, their special interest group in bioinformatics, computational biology, and biomedical informatics, where he also served on executive committees for their international conferences. Dr. Ghosh has also served on the editorial board for journals like Frontiers in Systems Biology, and chaired the Decision Analytics track at the Hawaii International Conference on System Sciences. Dr. Ghosh received his PhD in computer science from the University of Texas, Arlington, and completed postdoctoral training in biomedical informatics at UT Southwestern Medical Center. He's worked with Nokia Research, Nortel Research, and at Pfizer Global Research. With several federally funding research projects from the National Science Foundation, National Institutes of Health, Department of Defense, and the Department of Veterans Affairs, Dr. Ghosh's research interests include algorithms, optimization, stochastic modeling, and simulation. Today, we're happy to welcome Dr. Ghosh, and he will be sharing with us his epidemiological models used to quantify the spread of COVID-19. Models based on system dynamics and regression analytics, and then he'll enlighten us on how these models affect policymaking at different stages of the virus. And so without further ado, I want to turn it over to Dr. Ghosh, and thank you so much for being with us today.
Thank you, Balin, and thanks to everybody for attending the talk. It's my pleasure to be a part of this seminar series, we will be going over epidemiological models in general. So that's my title slide right here. epidemiological models and policy making for COVID-19. To start with, I have been working on a few different areas before, and with the onset of COVID, we were brought in a special group to study the impact of the spread in the Central Virginia region. So that's how I got started working on this area. It's a very exciting area because most of the models don't work, right? So we have plenty to do in this area. Now, what we will do in this talk is go over the general landscape of epidemiological models in general, what we have been doing a little bit in the Central Virginia region. So we have been looking into several different models from other competing groups across the US. So we'll give a little bit of a background on some of these models. And during the course of this modeling exercise, we'll talk about how some of the aspects of these models impact policymaking. So we'll not exactly show policymaking per se, but we will cover policymaking during the course of the modeling exercises themselves. Many of these slides are coming from my collaborators at UVA, University of Virginia, and to UPenn. And I'll talk about both of these because they are one of the forerunners of the COVID-19 models in the country right now. So with that, we'll get started. So infectious disease models, it's been there for the last 50 years or even more than that. So it's a big landscape of models that are out there right now. So why do we go ahead and build these models in the first place, right? So it gives us the insights into the mechanisms of the disease spread. Now, mostly we get data at this individual level, so which is called clinical knowledge. So for example, how long is the latent period? So when somebody's getting exposed, how long does it take for him to show symptoms, right? So these are individual clinical knowledge data that people generally gather. For different types of viruses, these values are going to be different. But so where does modeling come in? So these individual level knowledge that you have, how can it impact population level dynamics, right? So that's what we are trying to do with these types of modeling exercises. It also focuses our thinking. Now, this may come as a surprise, but what is social distancing, right? So we already know that, well, 6 feet apart, but how can you bring that into an actual model, right? And then the model can actually feed back to policy making because we can study, is it 4 feet or 6 feet that can make a difference or not, right? So many of the modeling exercises requires us to bring in actual parameters of importance, which can go back to feed policy making moving forward. It of course helps us in deriving new insights and hypotheses. So we'll show some very theoretical results. So we'll not go into the theory of these models, but some results which can tell you when is the peak coming, what is the magnitude of the peak, right, of infections. So that's where the mathematical analysis comes in on these types of models. Most importantly, it gives us a relative importance of the different processes involved and the parameters of the model. Okay, so it comes out that, for example, population dynamics is very important. Population density, is very important, right? In being able to control the infection spread of a region. It also comes up that travel into and out of the region becomes very important when it comes to controlling the spread. So these are the types of processes or parameters that come out of the modeling exercise for which the policymaking bodies should actually take special note because that's where policymaking gets impacted mostly. And many of these models, they motivate thought experiments and what if kind of questions, right? So what if we were to implement lockdown for a certain period of time? Okay, what is this period of time? Currently, there are no good answers. So we already know what is going on in the US and worldwide. So nobody has a proper answer of how long should the lockdown be, or whether we should have multiple phases of lockdowns. Should we actually, if there were to be a schedule of lockdowns for optimizing the infection spread, what should this schedule be? We don't really have answers to any of these policymaking questions. And that's the reason why this is a very new area with the kind of spread that we have seen for COVID. Many of these types of policymaking decisions have come in. I'm not going to go into these types of scheduling problems in this talk. I'll just lay out the basic groundwork of epidemic models, but this will kind of motivate some of these policymaking questions moving forward. Now, these points came from Heasterbeck and Roberts back in 1995. That's where they said, they proposed why would people work on infectious disease models in general. A very important piece that is missing in their report was predicting future trends. So the consensus is that we shouldn't really use these models to predict future trends because it's a highly complex system, a nonlinear and complex system, and many of the parameter values are often very difficult to estimate. For example, you must be looking at reports that, well, it takes 14 days, 7 to 14 days for recovery. Now this 7 to 14 days already has got a high variance. And then again, that's not a very true parameter because there are a lot of variances on top of that 7 to 14 day range itself, right? So quantitative predictions are virtually impossible. So you will see many models thrown around showing when is the peak coming, when are different states gonna outrun their hospital capacity and things like those. You'll have to take these with a grain of salt because what we did see is that pretty much none of the models work that well, okay? So with that, let's move forward with the role of data science. So this area of epidemic modeling does involve data science, but in a very different way than what we are used to. So we all know about big data, and if you have a lot of data set, you can actually make trends and identify patterns and do regression analysis and things like that. But data is what we do not have for a new virus. So think about what state we were in back in March, April, when we were trying to predict the peak. So we did not really have proper data about the dynamics of this disease. So even then, you would still want to work with real data because you would want to look into the actual rate of infection spread in a specific zone that tells you the real patterns that allows you to solve real problems, right? So we try to do the best we can with the limited data sets that we generally have, because that's what impacts public health policy. There are some challenges in working with data coming out from a new pandemic like COVID-19. So it's very difficult to get good data sets. So back in February, March, when we were doing all of these modeling, we realized that the number of infecteds for a specific zone, that's not really getting reported properly, because now we know that there are several asymptomatic patients, but back in March, April, that this was not known properly, right? So none of the models would fit the real trend lines that we were seeing. Okay, so it's very difficult to get good data sets, and the real world is messy. It completely depends on the testing levels that has been deployed in those types of regions. And then statistical methods for nonlinear models, these are nonlinear processes that are happening. They are always very complicated, right? So there are some modeling deficiencies that are there as well, and we've got to make assumptions over here. Now, some purists would say, hey, forget about actual data. Why not do pure theory? And we'll show some very simple theoretical results in this landscape of epidemiological models. Simple theory is also very important because it allows us to clarify some concepts, develop new methods. So currently some new simulation methods are getting proposed for handling COVID-19 kind of pandemics, which is kind of moving away from the standard landscape of epidemiological models. Long story short, we need a few brilliant theorists who can come up with new types of models altogether, but we need many strong applied modelers. So this word many is of special stress because what has happened since March is every state in the US had a body from the governor's office who were trying to work on these types of models. Every health science center, every medical center in the United States had their own group of modelers as well, trying to predict what will be the hospital capacity and when will the surge come in and things like that, right? So the huge pool of applied modelers were involved in working on these types of models, okay? Most of them were building on some existing theory, which unfortunately we now know doesn't work very, very well, right? So having said that, we actually reviewed about more than 20 different models across the country. And we picked up the top 3, which are the forerunners in epidemiological models for COVID-19 in the country right now. So these were the models that are being used by the Virginia Department of Emergency Management. And they're coming from 3 different institutes, UVA, UPenn, and University of Washington. So, some of the results that we are going to be showing based on these models are coming from these groups themselves. So for each of these institutes, they have been working on data every day, because the data with the new infected and new death and recovered values are getting are varying every passing day, right? So the models are getting updated several times a week based on this. There's inherent bias in the data. So some regions are deploying more testing than the other ones. So you've got to consider some of those aspects into these models also. And then documentation for some of these models have not been at par. So I could tell you from my experience across the 3 different institutes. So UVA had a much better documentation of their model, and they're one of the forerunners in these types of epidemiological models, than the IHME, which where you couldn't really feed in the kind of parameters you want for the Central Virginia region, right? So it's a much more ballpark kind of an estimate that we were getting from IHME, from UWash. Okay. So what is then a suitable model? So I've been talking about inaccuracies coming out from these modeling exercises, right? The biggest problem is that we don't even know the accuracy of our models until after the fact, right? So you're trying to predict the peak and you don't have an actual data on when the peak comes in. Of course, there's one country, China, where the peak happened before March, and you could try to fit the data with what happened in China. Turns out that pretty much all the countries that we have tried to fit the data with, the models worked quite well, barring China. So we didn't really know what was going on with the data that were being reported from there. Okay. Now models should be explainable in ways, right? And that's where our system dynamics and types of models are more important than some regression analysis or machine learning based models, because you would want to tie it up to real parameters of a zone, like population density, like the travel patterns of people in that zone and things like that, right? So regression models generally don't work so well when it comes to explainable models. And this is a general problem with machine learning, with the area of machine learning as well, that we don't quite have explainable aspects coming out of a model. So it's more of a black box kind of a model, right? So, and then the importance of these models is huge, because when you're trying to impact policy making, for example, there is an asymmetric risk that comes in. For example, when you're trying to plan hospital capacity based on the COVID-19 surge, too many ICU beds or ventilators, if your model predicts something like that, relates to very high costs, right? That you're trying to arrange for. Too few will cost lives. So the trade-off is very high over here. So the assumptions and the biases that comes into these types of models has to consider this kind of a trade-off as well. So with that, for COVID-19 in the US, 2 types of models came out as winners until now. One are the systems dynamics models, and the other one are the statistical models. So the first one, the statistical models, the IHME, University of Washington model, falls under this category. What those folks are trying to do is they're making projections based on curves. So it's essentially a curve fitting kind of an exercise. So they're looking at the daily rates of deaths, the daily rates of infected, and trying to fit it to a Gaussian distribution, for example. So everybody knows that, well, a peak is gonna come sometime or later, right? So it can be fitted to a bell-shaped curve, and now you can predict when will the peak be coming, assuming that there's going to be a bell-shaped curve somewhere in the horizon. Okay, so there are a few other, so I just simplified the process quite a bit, but there are some other parameters they do consider in training these models. And they also impose policy responses, like what happens during a lockdown, what happens during social distancing and things like that. One of the problems with these statistical models is that when data is too few, you don't have enough to train your model that way, right? So you're doing a regression based fitting. So you've got to have enough data across different zones, which may actually be varying significantly in terms of their population dynamics and travel patterns and things like that. So it's very hard for these models to make very good predictions. And we'll talk about that in a little bit also. Systems dynamics models are a lot better from that perspective, assumes an exponential growth in the number of infected, relies on estimates of the rate of spread, and the UVA model and CHIME from UPenn both belong to this category. Okay? So this is another slide from the UVA folks based on the three different types of modeling, the two different types of modeling exercises that are out there: systems dynamics and statistical models, right? So if you see the degree of a threat, so when WHO calls, the World Health Organization declares that COVID-19 is a pandemic, those have to come from surveillance exercises. So modeling can only do as much in terms of designating whether a certain virus should be declared as a pandemic or not. Okay, so that's why the modeling exercises are in the yellow zone for the degree of threat. Rate of spread, the systems dynamics based models, they fare quite well for the rate of spread, but not quite the statistical models, because during the initial stages of the pandemic, you don't have enough data to fit it with, right? So that's where the statistical models don't fare well enough. Surveillance again becomes important for rate of spread. The extent of spread, that is generally for extent of spread, you're talking about the magnitude of the peak. So systems dynamics models become very important for the extent of spread, but not quite statistical models, because if you're doing a nonlinear fit to the number of deaths, you're not really bringing in the actual population of that zone. So you would not quite know what should be the magnitude of this peak, so to speak, right? So that's where the statistical models have a problem. Timing of the peak, most of the two modeling methodologies fairly do well, and so does the severity of the disease. Okay, so with that, let's talk very briefly about these three different types of models. UPenn's CHIME, UWash's, University of Washington's IHME, and then the UVA model. So CHIME uses what we call the SEIR model, susceptible, infected, recovered. So this is the most popular modeling exercise and falls under the systems dynamics set of models. What happens here is you have a set of susceptible people, which to start with is your entire population in a zone, right? So the susceptible population, they transition over to infected, depending on the exposure to infected people. And then from infected, you go to recovered or maybe even death, right? So right now, let's just consider that recovered and death, they're pooled together into a single state, okay? Now, hospital bed and ICU bed utilizations based on these models are done through fixed ratios. So what do we mean by that? If your number of infected is a certain value, you would consider, let's say 20% of infected population is going to be hospitalized, right? So considering that, you can now calculate what is the hospital capacity, hospital requirements that you're going to be looking at in the future, okay? Now, each infected person is modeled to infect a few other people. This is dependent on a parameter that we call R0, and we will talk about the R0 parameter moving forward. It reflects a realistic spread during the early and middle stages of a pandemic, and that's why systems dynamics models are very useful. And of course, it's a very simple model, very easy to implement and run. Okay. However, a problem that comes in with some of these systems dynamics models is how to impact policy responses. How do you even do the what-if experiments? For example, how much of an impact social distancing is going to have in the infection spread, right? To emphasize on that point, the policy responses. So here's a curve where you're seeing that the blue curve is no response, so you're not doing any social distancing. The red curve is when you are doing social distancing, but you have it in your model in a specific way. You're just reducing the rate at which one infected person is infecting others, okay? So this is a fixed value that you are using for every infected person. In order for that person to infect others, you're just reducing the probability of infection over there, right? So what that does is it pushes the peak forward, okay? And of course, reduces the magnitude of the peak also. But then social distancing in a proper way, or a lockdown in a proper way, should be implemented through sequestration. For example, a certain group of people are sequestered so that they don't run into the susceptible pool, like they're not going to be interacting with infected people as much, right? So that's another way of implementing social distancing, or lockdown, if you will, right? If you were to do it this way, then you see the green curve, which does not push the peak forward, it only reduces the magnitude of the peak. So how do you implement this policy of social distancing versus lockdown is up to the modeler himself. And there was a lot of variance and unanswered questions in terms of implementing proper social distancing measures into our models and all. The best option is likely in between, that it has to be a combination of some kind of a sequestration and reducing the rate of spread from every single individual and all. Okay. So moving over to the UVA model, UVA uses something called patch sim. Their model is also based on a variant of the susceptible infected recovered model, the SEIR model. Okay, and we'll have a few slides on the SEIR model and the SEIR model, some variants of that UVA is using, because that's the most popular modeling technique in this domain right now. They also consider travel data. Now, the UVA model is much more detailed because they are looking at, let's say for the Central Virginia region, they're looking at every zone separately. They're looking at the infected population, how that is growing for every single zone. They're also looking at travel data between these zones, okay? So based on that, they're trying to figure out what is the probability of a spread from one highly infected zone to another less infected zone, okay? So this is a much better way of modeling this kind of disease dynamics than what Chime from UPenn have been trying to do. They also did calibrate their model. So this group has been working on infectious disease for the last 20 years. They have calibrated their model on actual flu spread over the past few years. So the model does have proper credibility that way. They do use county data. They are using Monte Carlo, Markov chain Monte Carlo particle filtering methods to do the parameter fits. Because at the end of the day, there are quite a few parameters that you'll have to estimate from these types of models. And there's a lot of uncertainty related to these parameters. Like at the zone level, is the rate of spread from one individual to others, is it different for different zones? Is the rate of recovery should be different or not? And there are many other of these parameters where variances may come in. The travel data is of course different for different zones also, right? So they're trying to fit their models to the observed infected and recovered and death numbers from that zone and using Monte Carlo techniques for doing that. Now, they do implement policies in two different ways. So, for example, social distancing or lockdown. So they either do slowing or pausing. Now, slowing would mean that social distancing will reduce the growth, but it doesn't fully stop it, okay? So you're essentially saying that one individual, the likelihood of one individual infecting 3 others, we are gonna reduce that to, instead of 3 others, we'll reduce it to 2 others. Okay, so that's what we mean by social distancing, reducing the level of spread, right? But it doesn't fully stop the infection, okay? Pausing is kind of a lockdown where you say that, well, social distancing or lockdown pauses the growth for that specific zone where lockdown is being administered, okay? So we have seen that with pausing based models, they fit the post-lockdown data a lot better than slowing based models. Okay, with that, the IHME model, University of Washington. So this is very different from the system dynamics models that we just mentioned, the statistical model. They are looking at the COVID-19 deaths and fitting it to a nonlinear distribution, a Gaussian distribution. As I mentioned before, they're using a more full-scale simulation for the model to predict the number of infected, and from there, what is the hospitalization capacity that we need? How many ICU beds, how many ventilators, and so on and so forth. This is not an SIR or SEIR model, so it behaves very differently. And you would have seen reports that like the IHME model has been in the news for a long time because the number of deaths that they have been predicting was much fewer than any of the other models that are out there, right? So that's why that model was getting a lot of media attention that way. However, the problem with this model is that it is solely dependent on the data, and the data is biased because the number of infected and the number of deaths squarely depends on your testing rates. So if you have not tested everybody, so you don't quite know how many people are truly dying because of COVID, right? So for a nonlinear model like this, the quality of the data becomes very important. And that's why you may have seen in the news that the IHME model predicts 100,000 deaths by the end of July, and they suddenly like reduce their numbers to a lot fewer in another couple of weeks or so. And we have seen that as well back in March, April, that even for the Central Virginia region, like the IHME model's predictions varied by about 25% every week, as and when new data was coming in. Okay, so even then, this model is giving us a different perspective for the COVID-19 spread, and it was also used in our in-house modeling exercise. Another problem with the IHME model is that implementing policies becomes very difficult, because if you're not considering actual parameters of contacts between people, this is just nonlinear regression that you're doing. How can you truly implement social distancing or lockdown kind of measures, right? So the UWash team does have different ways of implementing that, but it is not quite the physical way of implementing social distancing or lockdown. So the key takeaways from the current landscape of modeling, epidemiological models in the country, is that CHIME pushes the peak too far in the future. And it also depends on how they model social distancing, lockdown, so on and so forth. IHME, they generally have a very conservative estimate in terms of the number of infected and the number of deaths. UVA and IHME, both models, UVA is somewhere in between CHIME and IHME. UVA and IHME, both models get better with time as more data is available. The dearth of initial testing, it impacts all of these models in a big way. Okay, and many of these parameters, like what is the probability of one person infecting how many others per day, these types of parameters were derived from the data reported from China back before March, and they had their other problems with those types of data. Also, we figured out that CHIME is better used as a decision support tool and not quite as a forecasting model, because the forecast of their peaks have not been on the money as much. Okay, and very recently, current efforts are kind of considering all three types of models and doing some kind of an averaging of the predictions of these models. And that we feel is the best way of doing it, because no single model is being able to predict the pandemic spread in its entirety. Okay, so with that, we have been talking about SIR and SEIR models. So this is more of the historical perspective of these types of models. So let's go a little bit in depth into what these models are. So we just mentioned that S is a susceptible compartment, E is exposed. So these are folks who have been exposed to the virus, but have not started showing symptoms as yet. Okay, and then when they start showing symptoms, they go into the infected category, and from infected, you go to recovered or death. Now you can actually pool both recovered and death counts together into the R compartment. So this is the systems dynamics models that we have been talking about. Both CHIME and UVA are using these types of models in their modeling exercise. Okay, so with that, now how do you go about modeling this kind of a process? Now, if you consider certain rates, so lambda is, let's say, the rate at which folks from the S compartment transition to the E compartment. Okay, nu is the rate at which folks from the E compartment transition over to I, and then gamma is the rate at which I to R transitions are happening. Okay, so with that in mind, if those are your parameters of the model, then lambda can be modeled as a certain probability of infection, which is your beta, times the number of infected you have in the population. I is the number of infected that you currently have in your population, N is the total population size. Okay, so now you're getting kind of a probability of every person being able to infect how many more. So how many people are going to transition from S to E? It's this value lambda times what is the current size of your susceptibility. Okay, so that will tell you how many folks will move over from S to E within the next day. And all of these parameters are being used at a per day level, because we are fitting it to the data at a per day level with new estimates coming in. Similarly, rate of progression to infectious state, nu. So from E to I, we call it a latent period, right? So the latent period has been reported from other studies from individual level, where people have seen that when you have been exposed to the virus, how long does it take for you to start showing symptoms and start becoming properly infectious to others, right? So that's what we call the latent period. And this has been done with controlled studies on a group of people who got exposed to the virus and have not started showing symptoms as yet. And then rate of recovery, again, from individual clinical studies, people have reported that generally about 7 to 14 days is your rate is your infectious period. So that's how long it takes for somebody from going from the I stage to the recover stage or to the death stage. Okay. Now with that, with this simple setup, you can now write up differential equations for this model to be able to solve it, right? So differential equations, by the way, is just one way of solving these types of compartmental models. So if you wanted to just go in a little bit more details about the ODE-based setup, so ds dt is how your S compartment is changing. So S is a set of susceptible individuals that you have. So how is S changing with time, right? And we already saw that beta times I over n was your lambda. So the rate at which you are transitioning from S to E, that multiplied by the current value of S, that tells you how many folks will transition from S to E every time period, every delta t, okay? So similarly, you can write down the differential equations for the other states that you have in this model, okay? Now differential equations is just one way of doing it. There are much more easier state-based models as well that we will see in a little bit. Now SEIR is just one of the most standard modeling exercises, and that's what is currently getting used in the COVID-19 pandemic. But over the years, there have been other models that have been proposed. So what if I don't have enough data on recovered or death counts? So then I would just use SEI because I don't know what the recovered or death values are, right? So I would just go from S to E to I in a model like that. What happens if there are reinfections? For now, right now, we are getting reports that even after somebody has recovered from the virus, they're still getting reinfected, right? So now your R compartment in the SIRS, the SEIRS model, your folks from the R compartment can go back to the S compartment, right? Because there is a chance of reinfection, so they are still susceptible to the virus, okay? So depending on the actual biology of the disease, there are many variants of these models that have been proposed in the literature also. For example, leptospirosis has chronic shedding state. So over there, what's happening is from infected, people are not just going to the recovered or death stage, they have a much more chronic stage coming in, which is the C stage over there, okay? Now, if your pandemic is slow moving, this is not quite the case for COVID-19. COVID-19 is a very fast moving case, fast moving virus, right? We already know that. But then there are other pandemics in the history of mankind which are much more slow moving, okay? In situations like that, you have to bring in demographics. So what is the birth rate of individuals in a zone? Because that is gonna impact your susceptible compartment. How many folks are susceptible to the disease? That is not staying constant anymore because new people are getting born and some people are just dying of general causes, right? So there are birth rates and death rates that have to be considered here because the actual population of that zone is not constant. Make it even more interesting by bringing in travel into and out of these zones also, right? So those are the extensions that have been proposed. Now, going into more on the theory sides of it. So we wanted to show a few theoretical results. So if I were to have lockdown, for example, so lockdown would mean that we are not getting new infections as such. People are not moving about. So this exposed category becomes very important because these are the folks that have not been truly identified and they can transition over to infected within a certain latent period of time, okay? So what are you trying to achieve with a lockdown? You're trying to make sure that the number of exposed in that population, in that zone, really goes down to zero. Because if that happens, then chances of picking up new infections is going to be much fewer moving forward. So now you can just solve this differential equation for the exposed category only, considering no inflow of new exposed into the system, and you will get an exponential distribution like that. Turns out it doesn't fit the actual exposed compartment as we have seen for the SARS that happened, the original SARS that happened back in 2004. Okay, so it follows a bell-shaped curve. There are different modeling tricks to solve this. The exposed category can actually be broken down into several subcompartments to be able to match it with a Gaussian distribution like what we see for the original SARS. So this is called a boxcar model. So we will not go into the details of these types of models. Let's go into the R0 parameter, which I'm sure most of you have heard that the R0 for COVID-19 is between 2 and 2.3. R0 means that on an average per day, how many people, so one infected individual, how many people can that infected individual infect, right? So you're saying that about 2.3 more people will be infected from one person every day. So that's a very ballpark definition of what your R0 is. Now, if your R naught is less than or equal to 1 for different types of diseases, then the disease dies out automatically, and we really don't have to stress about it as much. For R naughts greater than 1, that's when the disease can invade the population, as we see for COVID-19. And that's where all the disease control strategies and outbreak dynamics come in. So can I now calculate the probability of a fade out? Okay, what should be my vaccination level? How many folks do I have to vaccinate at the minimum in order to check the infections? Okay, so these are the policy making aspects that come in, which are tied to the R naught. Now, you can compute R naught in a specific way. In the interest of time, I would skip this and show how the R naught gets used in a policymaking stage like vaccination levels. So consider this. So your R effective, which is the effective rate at which one person is infecting others, is dependent on the original R naught multiplied by the current number of susceptibles in the population divided by the total population. Okay, so that's what your effective R is. Now, as the pandemic progresses with time, the number of susceptible keeps reducing, because we are assuming no reinfections. So we are assuming that if a person was infected and got recovered, he's not going back to the susceptible state anymore. So they are immune to the disease. So when that happens, the number of S, the susceptible count, keeps going down. Okay. Now what that will also do is it will drive your R effective down, right? So with time, as more and more people are getting the virus and being recovered and recovering from that, my chances of this virus being more of a pandemic is going down also. And you'll see in this curve, when R effective is greater than 1, the susceptible, the green curve, shoots down very quickly. So it has infected so many people that there is not many people around to infect anymore, because all of them have, let's say, recovered and have grown immune to the disease. Okay. However, at equilibrium, we call it an endemic disease. So at equilibrium, when your R effective is equal to 1, that's where things can be a little bit different. Okay, so I'll move forward. So this brings up the question of herd immunity. And again, you may have seen reports on herd immunity. So it says that, okay, if my R effective has to be less than 1, and that's really the goal, my R effective has to be less than 1. If it is more than 1, very hard to check the pandemic spread, right? So we want our R effective to be less than 1 in order to be able to check the disease. For that to happen, you can just do the math from this expression right here. So you're considering R effective to be less than 1. So what percentage of the population, so 1 minus 1 over R naught multiplied by S, that's the number of people that we need to vaccinate or to make them immune in order for our R effective to be less than 1. Okay, so that's your vaccination policy, because that's what brings in herd immunity in a zone. Okay, so that's where these types of SEIR models become very important. Just to summarize with the R naught values, it's the most popular epidemic threshold. There are other thresholds as well, but the R naught gets used a lot to quantify the severity of a disease. Okay, so for very high R naught values, of course, the disease can take pandemic proportions and all. It helps with the initial rate of pandemic growth, prevalence of the peak, final size of the epidemic, mean age of infection, so on and so forth, the vaccination levels, and so on and so forth. Okay, so now we just covered a very simple modeling exercise, which is the SEIR model, which is the simplest one that is out there. There are other pieces here. So that's what we and some of the other groups are doing also right now. So deterministic versus stochastic. So the model that we just presented using differential equations or just state-based models, it's deterministic. So every time you're running this model, you're going to get the same value out of it, as long as it's being run on the same data set. What is stochastic? You throw in probability. You're saying that, okay, even though one person is likely to infect 2 others, that is not a constant value. So there is a probability involved over there. So now you're going into more agent-based simulations and those types of exercises to bring in the stochasticity. I have a few slides on the stochastic part over here, but I will be skipping all of that in the interest of time. Just to give you a feel of the different types of the more in-depth modeling that comes in with this generic setup. Then there is discrete versus continuous time. So if you're solving it with differential equations, it's continuous time. It's moving every delta t forward. But technically, our reports, the number of infected per day is discrete, right? So every day we are getting the counts. Okay, so how do I change the models in order for it to relate with the discrete values that we are seeing? Discrete versus continuous state variables. So if you're solving it with ODEs, your number of infected can actually be a fraction, can have a fractional value over there, because differential equations are not just going to run on integer values and all that. So how do you bring those in? Random mixing versus structured population. So there have been a few models proposed, which is looking at the contact rates of people, which you will contact tracing kind of exercises and all, and looking into these mixing propensities of people. Okay, that's what to some extent the UVA model is trying to do. And then homogeneous versus heterogeneous. The model that we just presented is a very simple homogeneous model that I have equal chance of infecting so many others. But that is only considering that the population is very homogeneous and everybody has the same chance of getting infected. How do you bring in heterogeneity into a model like that? So those are some of the more detailed aspects. So this will give you a pictorial view of what we are talking about with the mixing component, for example. So random mixing, multi-group mixing, so you can actually break it down into different groups. Social network-based mixing. Somebody who has got a larger social network or interacting with several people has got a higher chance of infecting others. Okay, so some of those pieces come in: spatial mixing, individual-based models, so on and so forth. So these are more of the the advanced modeling aspects. I'll skip some of the theoretical pieces and get into the data needs now. So we do know that we want to talk about data science a little bit. So where is data science fitting into this modeling exercise? We need data to fit, to build the model in the first place. So we want individual clinical data, okay? How long is the latent period? How long is the infectious period? What is the immunity level? So what is your chances of getting reinfected? We need population data. What is the population density of a zone? How many total people are there? What are the birth and death rates in that zone? And rates of contact between population groups. So we just talked about mixing in the previous slide. So what is the mixing level in that zone? So some of those pieces come in, and the epidemiological data like R0 values has to be considered also. So that's where data science comes in to be able to infer some of these parameters. Data science also comes in to fit the model accuracy. So you're fitting it with the time series, which is your infected numbers per day. So you're fitting it with those types of time series data that comes in. There are age level pieces that come in also. So people at different age group may have a different chance of infection, different chance of recovery rates and all. So you can actually bring in those compartments into these models. Okay, so with that, here's a chart of the SARS, original SARS back in 2003, showing the contact tracing network. Data like this is currently not available for COVID-19 because of privacy and ethical issues and all of that. So it's just showing that if these types of contact tracing data can be overlaid onto your models, you can actually make better predictions of the mixing levels between people and between zones and all. Okay, so with that, I would just have 2 more slides on some of the policy making exercises. So we did run some proper regression analysis on these types of data, right? And we know that we have a very data science related crowd over here. So this was done over the 50 states in the country, and we were trying to identify factors that influence lockdown. Okay, so that was what we were trying to do over here. So what we did find was airport traffic. So you will see air over here. PD is my population density, testing rates, and age 80 plus. These are the primary factors affecting the peak or the number of infections. It's a simple regression model across the 50 states of the United States and all. Okay, so airport travel. So people are picking up infections primarily through airports, through airport travels and all. Testing rate is obviously important. That has a huge impact on being able to infer when to impose the lockdown in a certain region. Population density is very important. A place having high infections but low population density is not in the red zone as the place with high infections with high population density, right? So that's quite obvious. And age group, we have seen that 80 plus, that's where the number of infections or the number of death rates is much higher for the current COVID-19 data. We did not see a gender bias. We did not see ethnicity playing a role into the number of infections or into the death rates, though, based on the data that we have. And finally, we'll keep it to the hospital capacity simulation. So why are we doing all of these things? So we are building a more detailed simulation for being able to plan hospital capacity from this, right? So we are looking at COVID-19 patients coming into the hospital. We are looking at general patients that are out there already. We are looking at ICU bed usage, ventilator usage, so on and so forth. And you basically have people with COVID-19 coming into the hospital and mixing with others. So you have to minimize that level of mixing between these types of patients. So A simulation, a full-fledged simulation for hospital capacity for a problem like this has to consider not just COVID-19 patients and your epidemiological models, also has to consider the rate of other patients coming in and where are they housed in the hospital, right? So for this, we call it a system of systems simulation exercise. So that's more on the research side, and takes time to develop something like that, because you're trying to bring in all different hospital components together and trying to figure out how they're interacting with the COVID-19 patients in a scenario like that. Okay, so that's also on the policy making side where we are trying to do hospital capacity planning. So with that, I know that I've run just a little bit over time, and I would stop there and start taking any questions that you may have.
All right, so I've been keeping an eye on the questions. Thank you, Dr. Ghosh. That was, I asked you yesterday if this was a technical talk, and you were like, not too much, and it was, so we always appreciate that.
Okay,
before we get to questions, because I have a few in my private chat, and I have a few that everyone can publicly see, I wanted to just remind everyone that Preetam is the second speaker of a series of 4 speakers that are going to be on COVID-19, health, and business. Oh my gosh, I didn't write his name. But 2 weeks ago, we had a speaker who, I'm sorry, I'm blanking on his name. Dr. Custer is going to get at me about this, who talked about Marriott and the leadership challenges running an analytics team. And 2 weeks from now, we're going to be welcoming Dr. Fern Halper, who's Vice President and Senior Research Director at the Transforming Data with Intelligence, TDWI, which is a, anyway, I have nothing to complete that sentence with. And I recognized her name a couple weeks ago because she wrote Big Data for Dummies, which I read. I don't know if anybody else here did. So join us a fortnight from now on August 26th with Dr. Halper, who will be talking about her research in how COVID has changed the analytics professionals' careers and analytics and industry. And real fast, I want to remind everybody again that these talks were organized by the VCU Decision Analytics Alumni Group and the Tidewater Richmond chapter of Informs. And we want to thank the School of Business, which was Dr. Custer, Dr. Paul Brooks, Rachel, Gabby Oliveira, and Brittany Graysick, who's recording this while on vacation. So I am sorry for, thank you so much for helping us all the time. And 2 weeks ago, we had Greg Bucko, by the way, from Marriott Hotels, who is an alumni of the DAPT group. So the first question, Dr. Ghosh, we had was, how do researchers estimate the rate of spread for models like CHIME when there's no historical data available for new diseases or a pandemic in the early stages?
That's actually a great question, and we struggled with it, is the right answer, I would say. But yeah, so what we did do, so the modeling exercises in the US started from March, and that's why I said that a lot of the parameters were picked up from what was reported back in China. So the R0 values, for example, in terms of rate of spread for every individual being able to infect so many others. So that's a very important primary value that you need to consider. So WHO reported a value between 2.1 to 2.3 before declaring COVID to be a pandemic. Right? So any value of R0 greater than 1 means that if one individual is only impacting one other or less, so that's when the R0 value is 1 or less, right? So if one individual can infect multiple others, that's when the R0 value is greater than 1, okay? And that is very important for being able to model these types of exercises. So yes, we are looking at data from China to be able to, like back in March when we started doing this exercise, and then those values kept getting refined with as and when new data was being available in the United States. But yeah, and that's the reason why back in March, all the predictions went haywire. I can give you an idea of how bad it is. So CHIME, UWASH, IHME, and then UVA, the 3 models, we ran a comparative exercise over there. And the peaks that they reported were 2 months apart from each other. So CHIME was reporting a peak for the Central Virginia region, I would say. So CHIME was reporting a peak maybe in May, UVA 2 months after May, and then IHME 2 months after that. So that's the level of variance. So technically, it is basically saying that we are just rolling a dice and we have no clue what's going on. Okay. So as and when new data is coming in, you have more, confidence on these rate of spread kind of values. That's when the predictions started converging together, which is what is happening in the country right now. So the models are working a lot better right now. But initially, it is anybody's guess. So we were also picking up parameters from the original SARS back in 2004, trying to say that if SARS-CoV-2, COVID-19, is similar, were to be similar to the original SARS, let's just use some of the parameters that we had estimated for the original SARS.
Okay. Well, that makes a lot of sense. I guess real fast, we haven't had any pandemics here in the United States for a little while, or we missed out on the early SARS and the bird flu, and swine flu didn't affect us as hard. So I understand. Rolling the dice. Wow, what a wonderful way to put that. Okay, another question we have is, are there any groups or institutions publishing composite models of the three leading models today, or is it more of a comparison like what you described?
Yeah, well, so I saw one paper in the past month that has done this, a composite model. So they're actually running it not just for the 3 to 5 leading models that are out there in the country, they're also doing it for different parameters, because you have to take this with a grain of salt. Even let's say if the UVA model were the best performing one, if we were to say so at this point of time, the parameters that they use for social distancing or hospitalization rate can vary quite a bit. They are trying to estimate their parameters from what they are seeing in Charlottesville, for example, which may not match up with what we have in the Richmond area. And we have seen that the hospitalization values, for example, so Chime was using about 25%, saying that, okay, about 25% of infected will be hospitalized. UVA was using 5%. Now it's anybody's guess that what should be the right value, right? So composite models is not just across different models, but also across different parameters. Because if you're trying to make a prediction for a peak, you also have to run it for several possible values of these parameters, because we don't just have confidence on what the true value should be.
Makes sense. All right, well, we have 2 more questions, and I think we should just do them live. I understand the lunch hour is over. We've had some participants leave, but this recording will be sent out later on next week, and I think we should just spend the next couple minutes here going through these last questions. So the first one is, or the second to last one, excuse me, has anyone looked at the models? We're predicting various points of time, and then have people been reflecting on how those models performed, their accuracy?
Yeah, so that's one of the ways of publishing, I would say, is that you're breaking up the data piecewise. So how do we even say that there is any confidence that we have on these models, right? So you're not looking at the entire data set, you're breaking it down, saying that, okay, let's see how my model predicts after the first months of data. Okay, and you're making predictions. You already have the second months of data available, right? So that's one way of trying to bring in it's like a cross-validation kind of a technique in machine learning, if you will, right? So that's what people try to do in terms of bringing in some credibility on these models. Otherwise, they will not just, nobody will believe any of these models if you don't have any credibility exercises. Yeah.
Okay, makes sense. And then real fast, how do you think this event, COVID-19, will change modeling in the future? Or do you think political leaders will have to learn more about modeling and disease spread? And what are your insights on that?
Oh, I mean, the modeling field for epidemiology may actually change a lot right now. Of course, COVID-19 is going to change the way we are going to live, right, moving forward. It's going to stay with us for a long period of time. Even the modeling exercises will change a lot, because what we have seen in the United States is how bad these models have been, right, in the past, towards the beginning stages of the pandemic and all. There are much better modeling exercises that are coming in. For example, Google is looking at cell phone records, trying to look at traffic traces, how people are traveling during a pandemic. That kind of data is very important to be able to identify the level of spread between different zones and all, okay? That is currently, with the privacy concerns and all, they're not quite sharing that kind of data to the rest of the public. But moving forward, when we are trying to create an intelligent disaster response system These types of cell phone records data will be extremely important to be able to make any kind of prediction. You cannot just look at your susceptible population or your total population and say that, okay, one person is going to infect so many others, right? That's just very simple. That works for slow moving diseases, but not quite for COVID-19. And the traffic patterns plays a huge role in this. So Google have started collecting those types of data sets. We'll be in a much better position next year if COVID comes in with a new strain and we are again scampering to figure out when is the peak coming and all. We'll be in a much better position because the different states in the United States, we are working with Google to be looking at these types of traffic patterns and being able to predict the spread a lot better.
All right, makes sense. Well, thank you so much for being here today. We want to thank all of our participants. I saw somewhere in the 40s, which is always a great turnout. Very, very educational. Seeing a lot of math that I haven't seen in a while since grad school.
I knew I would skip those, but I didn't know how many I had to skip.
No, they were great. We can't thank you enough for being here, and we hope someday to have you back live in person.
Thanks. Same here. Thanks a lot again for this opportunity, and thanks to everybody for attending. Yes.
All right. Thank you all for attending, and we're going to close out this meeting, and we hope to see you all in 2 weeks.
Sure. Thank you.
Bye-bye.
Bye.